Dear colleagues, I would like to thank you, firma Pfizer, for this possibility to be our sponsor for this meeting. And I will continue now with the next session, which is very interesting because we received the questions before to start the session for the tetralogy of the follow. But before that, we have one more question, maybe Professor Wiley. I think she is still here. The question is about how often we could find non-compaction in patients with the ventricular septal defect.
Okay, thank you. Thanks for the question. Hi, I'm still here. So for LV non-compaction, I think you do find in various type of congenital heart disease. Certainly we have seen in patients with VSD. But in a lot of time, it's like we call increased tuberculation. The appearance looks non-compaction, but myocardium function seems still maintained. They are differ from non-compaction cardiomyopathy. But the thing is, in later life, I find some of these patients with LV increased tuberculation do have develop or presented like having a left ventricular diastolic dysfunction. I think one of my fellows has looked all the patients in congenital heart disease in our group, and he has written a paper, hopefully it will come out. If you find this patient with this appearance, we call non-compaction type appearance, does have problems. The event-free survivals are lower than patients totally don't have it. Thank you.
Thank you, Professor Lee.
No problem.
So we will continue with the next session. This is the session for the tetralogy of the fellow. And I would like to invite Professor Yan Ho to starting with the morphology of this very interesting disease. Professor Ho?
Session is on tetralogy fellow, and I'm going to present the morphology. So to start with, fellow described this combination of lesions responsible for a blue disease back in 1888. And the 4 features are listed here. I'm sure you're all familiar with that. So basically we have inflow here, and we have an obstruction to the subpulmonary outflow tract. These lesions, combination of lesions, have also been detected in utero. It accounts for about 5% of congenital heart diseases, so fairly common. There are 2 major forms to it. One is with pulmonary stenosis, the other with pulmonary atresia, also previously known as pulmonary atresia with ventricular septal defect. Now, the first surgical repair was way back in the 1950s, so there are adults who have had repair in childhood these days. So the lesion is within the right ventricle, as we said before. So looking into the right ventricle, there are various muscle bundles that contribute to this lesion. But first of all, then, this diagram shows a ventricular septal defect with aortic valve just behind it. The muscle bundles of significance in the right ventricle then are the structure here, the outlet septum, which is tilted anterior-calf-led direction. And over here, septoparietal trabeculations, which also contribute to the subpulmonary muscular obstruction. Down here, we have the septomarginal trabeculation, of course, the moderator band, characteristic muscle bundle crossing the right ventricular cavity. And up here, ventricular infundibular fold, which tries to come in and fuse with the septomarginal trabeculation over here. So all in all, in this part of the outflow tract is where the stenosis or the narrowing of the passage to the pulmonary outflow tract would be. So then, if we take a heart specimen with fellow tetralogy, open it up, you will notice that I have cut through the outlet septum here. So I have 2 halves of the outlet septum displayed. The probe is showing you the aortic valve, and now I have cut through the pulmonary outflow tract, so you have two halves of it, and you can appreciate how narrow the outflow tract is here, just the width of a probe, so maybe about 2 millimeters in diameter, and this is the other half of that outflow tract. So essentially, if you take an intact fellow's etiology heart and we look up towards the pulmonary valve in this picture here, what we've done in this preparation is to cut through the outlet septum in this fashion and open up into the aortic valve, as you see here. So compared to the normal heart, as we see in this far right-hand panel, then a left-hand panel rather, we have ventricular infundibular fold, septomarginal trabeculation, pulmonary valve here, no sign whatsoever of hole here, of ventricular septal defect, of course, because it's a normal heart. Whereas here you have a ventricular septal defect, and these structures seemingly have come out and separated from one another. So in sort of short axis view, then we see in this configuration the deviated anterior calf-led deviation of the outlet septum, meaning the outlet septum, instead of running in this direction, has swung around to come up, squeezing the pulmonary outflow tract here. Just beyond here is the pulmonary valve. And over here, the aortic valve leaflets overriding a ventricular septal defect in kind of subcostal orientation, as you see on this right-hand panel. We see the aortic valve overriding a ventricular septal defect. Here's the tricuspid valve. And over here, a short axis or a section, cross-section through the outlet septum, squeezing very much the pulmonary outflow tract. And furthermore, the septoparietal trabeculations are hypertrophied, contributing further to the narrowing of this outflow tract to the pulmonary valve. So then we have postnatally hypertrophy of the septoparietal trabeculations, as well as the right ventricular muscular hypertrophy. But in most cases of fellow's etiology, there is a basic malformation of the four features, plus a variable extent of morphologic features, as we have listed here. The overriding aortic valve, what do we mean by that? If we take a longitudinal cut through a heart along the aortic valve, you will see that it is sitting above the crest of the ventricular septum. So in most fellow's etiology, the aortic valve is still committed primarily to the left ventricle, although you may have cases whereby the aortic valve is much more dextroposed to arise even more from the right ventricle, giving a double outlet from the right ventricle situation, but still associated with pulmonary outflow tract obstruction. A close-up view of this area here shows us that the ventricular septal defect has a muscular posterior inferior margin. So tricuspid valve is over here in this particular case, which is quite uncommon for fellow's etiology. We tend to have a perimembranous ventricular septal defect instead of a muscular ventricular septal defect. And you will note the pulmonary valve here, a little bit visible, pulmonary trunk or pulmonary valve area cutting cross-section, very small compared to the diameter of the aorta, and the proximity to the coronary arteries. So important to bear in mind, especially when intervening to deliver a prosthetic pulmonary valve in cases with previously repaired fellow's etiology, for example. So variability in aortic override then can effectively change a concordant ventricular arterial connection to that of a double outlet connection from the right ventricle. There are various areas or places where there can be obstruction to flow to the lungs. You may have a stenosis or tending towards atresia at the mouth of the infundibulum pulmonary valve area, or within the body of the right ventricle, as we see in this heart here, where hypertrophy of the septomarginal trabeculation has virtually created a two-chambered right ventricle. And then further along in the pulmonary arteries, you may have more distally discrete areas of stenosis within the arteries themselves. And then there are a whole host of associated malformations to look out for, and we'll just look at a couple of these. We'll talk about Pulmonary Atresia later on, and I want to show you a case of absent leaflet of the pulmonary valve, just to give an idea of what these cases look like. And then there are all these other features also that may be associated in hearts with phallocetrology. So in this movie here, we have the right ventricle outflow tract opened up. Phallocetrology, we deviated outlet septum just there. But look at the leaflets of the pulmonary valve. They have not really formed to make competent semilunar cusp. They are just little blobs of mucoid-looking material representing the pulmonary valve. So so-called absence of the pulmonary valve situation. The consequence is usually a hugely dilated pulmonary trunk, plus or minus one of the pulmonary arteries will be dilated as well. And on this panel here, we have an endocast of the bronchial tree with the pulmonary arteries filled in. It's showing you view it from the back. This is the left pulmonary artery, and the main stem bronchi are very much compressed and flattened in this situation. The coronary arteries may arise normally, as we see in this example here, in a barren course of a left anterior descending coronary artery coming from the right coronary system. And there's another left anterior descending coronary artery here as well. So this is the region usually where the surgeons would like to sort of encroach, would like to try and widen and open up the pulmonary outflow tract. But this was noted in advance, so the surgeon made 2 apertures here and connected with a conduit. This is another heart, had previous repairs to thin areas here and open up the outflow tract. The ventricular septal defect has been repaired very nicely, hardly a patch material, hardly visible at all. And here we see the thinned out areas. The surgeon had sort of tried to remove some musculature. And here is the aberrant coronary artery in between. So the repair of phallocetrology might mean an atriotomy, closure of the atrial septum, patching of the ventricular septal defect, enlargement of the outflow tract, as we see in this heart, open up into the right ventricle. Here's the patch. It's a little bit endothelialized, with some remnants of suture material still visible through the fibrotic areas here, and pulling up the outflow tract that's been very nicely, widely opened up. And we see some thinning of the ventricular walls as well. And I think this might have been a sort of outflow tract patch, prostatic material put in. So here we are, the still image here, the patch, and some muscle around here. Here's outflow tract patch. So moving on to pulmonary atresia then, we have right ventricular outlet to the aorta via the ventricular septal defect. The nature of atretic outlet varies, type of ventricular septal defect varies, but I think what's more important is what exactly supplies the lungs in this situation. So we have 2 forms of pulmonary atresia with imperforate valve, or muscular atresia where there's no remnant or sign of a valve at all, and less common in this situation is a solitary arterial trunk where there's no evidence whatsoever of intrapericardial pulmonary arteries. So some examples here. This is one with the outlet septum deviated, okay, an imperforate valve membrane, whereas in this one, there was a muscular atresia here, a small pulmonary trunk. Looking up here, ventricular septal defect, no outflow tract to the pulmonary trunk. The atretic segment was just inserted beyond this wedge of musculature. So the question then is, what supplies the lungs? You can have all sorts of variations, as we see in this diagram. You can have a duct, unilateral or bilateral. You may have two ducts with interruption of one of the pulmonary arteries, or you may have a combination, as seen in this situation, one side with a duct, the other side with collateral arteries, and so on and so forth. So if we start with looking at a couple of examples of those that have supply via an arterial duct. So an example here is the left-sided aortic arch, the normal configuration, the duct connecting to the pulmonary trunk and pulmonary bifurcation. Look inside, this ventricular septal defect, obliterated outflow tract, no way to get to the pulmonary trunk. In this case, we see an arch going to the right side of the trachea. So right side aortic arch. So the first branch would be brachycephalic to the left side. We have left subclavian here. This is a duct that had just been broken off, connecting to the pulmonary bifurcation. So variations even in the location of the duct. Now, what about the cases without arterial duct? You may have systemic to pulmonary collateral arteries, or you may have central pulmonary arteries. So let's look at some examples. You may have one segment or one lobe of the lung exclusively supplied by collateral arteries, or you may have a solitary arterial trunk where there's no sign of intrapericardial pulmonary arteries at all, and the lungs are supplied exclusively by collateral arteries. Then you have this situation, which we see more in our heart specimens in our archive, which I call a combinations kind of supply, in the sense that they are native pulmonary arteries and also some supply via collateral arteries, and some of these indeed do anastomose together. So an example or combination kind of situation, look at a narrow pulmonary trunk and bifurcation. Inside the right ventricle, aorta, but no pulmonary outflow tract at all. And turning around to the right side of the specimen, we begin now to see the right pulmonary arteries here. Just pull the aorta forwards, pulmonary trunk, left pulmonary artery, right pulmonary artery. This is the right main stem bronchus. So try and lift up here, the pulmonary bifurcation seen just here. And you see an artery coming down underneath, looping underneath this right main stem bronchus. This is the aortic arch going down, descending. We see systemic to pulmonary collateral arteries here. And we see a small one here. This is the one that's tucking itself underneath the right main stem bronchus and looping and connecting with the native pulmonary arteries. So there's anastomosis in the two regions, two supplies. And further down the descending aorta, then we have further collateral arteries going to both the right and left lungs in this specimen. So in summary then, you can have tetralogy fellow that range in spectrum from pulmonary stenosis to absolute pulmonary valve to pulmonary atresia. And not to forget that apart from the characteristic four features, there are very often associated malformations as well. And in those with atresia, you need to look for what is supplying, sending supply to the lungs. So thank you very much. This session is on tetralogy fellow, and I'm going to present the morphology.
Thank you, Professor Ho, for the very interesting morphology session. Before we continue with the next speaker, I would like to invite Professor Wiley also. There is little bit discontinuation of the session because Professor Wiley will maybe tomorrow will be not available to join us, but she's a very close friend of mine and is very well known in Bulgaria. So I would like to give Professor Lee and Professor Ho these prestigious awards for our Foundation for Cardiovascular Imaging that we given every year regularly for the speakers who is some of the big presenter and big achievement in the field of echocardiography. So this year, the Foundation for Cardiovascular Imaging give this awards for Professor Lee and Professor Ho for this appreciation, for the giving this teaching to during the software days. Thank you so much.
Very kind of you, Professor
Thank you.
Christoph. Thank you so much. Really, we're really honored.
We're delighted to be here. Thank you so much.
In the different way giving this certificate of appreciation, but I hope that we will be available very soon to be our guests face to face to present your presentation again to our audience.
Thank you.
I would like to give a short comments about the next upcoming course in the Royal Brompton Hospital, organized by Professor Wiley and Professor Hall.
Thank you. To see whether it's a show, yeah.
Will be the next September. And
Yes.
everyone who is interested is possible to apply for this course. It's really enjoyable to be there. So thank you so much. Thank you very much once again for this possibility to be together this evening and during this Software Echo Days 2021. Even
Thank you
on
very much.
online by Buzzet.
Yeah.
Thank you.
Thank you.
So we will continue with the next speaker, and this is Dr. Beatrix Castro-Verdes. She will present actually the echocardiography assessment of tetralogy of the fallow and tetralogy of fallow post-repair echocardiography assessment. Professor Castro.
Thank you very much. Thank you very much for the invitation to the talk as well. And we're going to start then this presentation that is about echocardiography assessment of tetralogy of fallow. Most of the first slides were actually already explained by Professor Ho, so I'm going to run through them quickly so we can focus in other aspects of the talk. So basically, let me just minimize this. Okay, perfect. So my name is Mireia Castro. I'm one of the pediatric fellows in cardiology at the Royal Brompton Hospital. And I've trained also previously with Dr. Wiley in echocardiography. I have nothing to declare for this talk. So reminding the definition of tetralogy of fallow, initially explained by Monsieur Fallow himself at the end of the 19th century. So the four features of tetralogy of fallow were consequence of the antelocephad deviation of the outlet septum in combination with a hypertrophy of the septoparietal trabeculations, as Professor Fo kindly explained previously. And that gives rise to a non-restrictive outlet Vsd, we can see in this image, aorta overriding that is committed therefore to both ventricles, then infundibular pulmonary stenosis and right ventricular hypertrophy. In the current definitions of tetralogy of fallow in most series, they include pulmonary stenosis at different levels, and we can talk about that in this talk. So basically, a bit of epidemiology as part of introduction. So tetralogy of fallow, as was previously mentioned, accounts for 5 to 10% of congenital heart disease, but it is also the most common cyanotic congenital heart disease in infants and in babies more than 1 month old, basically. And there's a slight male predominance, and approximately 50% of them carry the George syndrome by mutation of the 22q11 chromosome with deletion. And this can have also some extracardiac features associated, but most of the cases of tetralogy of fallow are not genetic or inherited and are new mutations or new cases. And there's also higher incidence in relatives, but it's predominantly in cases with 22q11 deletion. And what is the natural history of tetralogy of fallow? Well, inoperated fallow carries very poor prognosis, and approximately 25% of patients die within the first year of life, and approximately 95% of them, meaning almost all of them, will be dead at approximately 40 years of age. And this happens because the chronic cyanosis has a lot of comorbidity and carries ischemia, arrhythmias, exercise intolerance, and also there's risk of thrombosis and cerebral abscess and paradoxical emboli through the unrepaired ventricular septal defect. And we know as well that patients who actually undergo surgical repair, they have much better improved survival, with 85% of them living more than 35 years after the initial operation. And also we know that early repair in life is much better than a late repair in life, even repair at any age provided there are no increased pulmonary artery pressures, is beneficial. But we know that early repair carries less risk of chronic cyanosis and favors also the growth of the pulmonary artery. So all that reflects much better, much less morbidity and mortality, and much better survival in our patients. Approximately 1/3 of patients with tetraloopholothis and repair for tetraloopholothis will need an intervention in the future. So what is the role of echo in this disease? Well, echo plays a role in the diagnosis, in the intraoperative monitoring for surgery, and also in the follow-up and an indication for intervention. So basically, it's the most important imaging technique and often is sufficient, particularly in children and in infants, for the diagnosis of the test. Also, it can detect other features that can change the clinical outcome or the clinical course, or even the indication for surgery, like associated anomalies. And yes, it helps with risk stratification. So other imaging techniques are also necessary and important. So echo is the most important technique, but it's not sufficient in 100% of the cases. And sometimes we need to complement our assessment with a cardiac CT to see, for example, the coronary arteries or the pulmonary arteries much better, a cardiac cath to measure the pulmonary artery pressures in patients with collaterals or with patients who have almost pulmonary atresia, to see how the pulmonary arteries are and to confirm if there are additional sources of blood flow like PDA or things like that. And then the MRI is mostly used in repaired patients to also stratify them for the risk of sudden death and the need of an ICD or pulmonary valve replacement, for example. So we'll talk about it in this talk. So the first thing that we need to do with every patient that we want to scan with tetraloopholothis is to start a segmental analysis. So apart from the features of tetraloopholothis that had been described, it is very important to start just checking the situs, making sure it's situs solitus. That would be the case in most of the cases, that the systemic venous drainage is normal, that there's atrioventricular concordance and ventricular arterial concordance. So this is the norm in patients with tetraloopholothis, but it's not always the case. So we need to make sure we do a segmental analysis before we start. And then the subcostal pictures in infants gives us the most reliable image sometimes. And we can see, for example, in this modified short axis and oblique anterior view, in this view, the aortic valve in the middle, then tricuspid valve with the right ventricle inflow and outflow, pulmonary valve that bifurcates after the main PA into the left and the right pulmonary arteries. That would be a normal heart. And in this other picture, we can see a patient with tetraloopholothis that has anterior deviation of the infinibular septum, hypertrophy of the septal margin, the septal parietal bundles, then a small pulmonary artery, a pulmonary valve, and then in this case, the pulmonary artery is connected to both pulmonary artery branches. So they are confluent. We can see as a consequence the large ventricular septal defect that would give rise to a bidirectional shunt with systemic pressures in the right ventricle. And if we put color Doppler, we can see the same image. So basically this subcostal anterior oblique view demonstrating bidirectional shunt across the VSD, and also acceleration of flow that starts in color Doppler at a subvalvular level. So in the infundibulum, we can already see acceleration of flow suggesting a stenosis. And this is a TOE image that clearly reflects the main mechanism of tetraloopholothis. Is a mid-esophageal long axis view focused on the outflow tract. So the left ventricle outflow tract is on top of the image, connected to the aorta, that is at the same time overriding the septum due to this anterior deviation of the outlet septum, and that causes hypertrophy of the right ventricular outflow tract at infundibular level, and then we can see here the pulmonary outflow. So we're going to have a look at the typical features of tetraloopholothis and then at the different variants. So basically, the ventricular septal defect in most of the cases is non-restrictive and single, although multiple defects can happen, and also it could be restrictive, but those are unlikely. So in most of the cases, as I said, the ventricular septal defect would be large and unrestrictive, and therefore the right ventricle will have systolic pressure. So it would be equal pressure in the left and the right ventricle. It would be a bidirectional shunt across it. And we can see as a consequence, the right ventricle is big and is also very thick. Then sometimes when the defect is partially closed by tricuspid valve and gives rise to a small ventricular septal defect, in case there's important pulmonary stenosis, then the right ventricle would be a suprasystemic pressure. So that patient would do more badly than if it had a bidirectional shunt that can help a bit like escape for the overpressure on the right side. So another view of the overriding aorta that is connected therefore to both ventricles. And we can see here from the subcostal anterior view, also the overriding of the aorta and the outlet ventricular septal defect. Sometimes this overriding of the aorta is exaggerated and is connected to the right ventricle more than 50% of the measurements of the valve itself. And in those cases, we say that is tetraloopholothis with double outer right ventricle, because the right ventricle would be connected to the pulmonary artery and then with most of the aortic valve. And then one of the features that differentiates the double outer right ventricle from the tetraloopholothis would be that in case of tetraloopholothis, the mid-aortic continuity would be preserved, and that would not be the case in case of double outer right ventricle. So I can show you images on color Doppler of this subcostal anterior view. So it's an apical view. We can see the outlet ventricular septal defect with bidirectional shunt. And in this case, there's no structure, no obstruction to flow and no aortic regurgitation. Okay, so the infundibular pulmonary stenosis in the short axis, peristoneal short axis, would look like a very thickened and muscle hypertrophied at the level of the subpulmonary area with acceleration of flow and turbulence during mostly systole. And then on Doppler, on continuous Doppler, we would see this duck-shaped Doppler flow with high velocity. So to estimate the exact level of obstruction, sometimes it can be obvious in 2D, like is in this case. And sometimes when the valve looks small on them, there might be acceleration of flow along the outflow tract. We can use the pulse Doppler at the level of the subvalvular area, at the valvular area and the supravalvular area, just to demonstrate at which level exactly the obstruction happens. So echo has to make clear if there's combined pulmonary stenosis or only at one level, because that would have implications for surgery. And then regarding the right ventricular hypertrophy, as seen in the previous images, that would be the consequence not only of the pressure load of the ventricle for the pulmonary stenosis, that in most of the cases is severe, but also because of the systemic pressures across the non-restrictive VSD. And the ventricular function in a tetraloopholothis, the first diagnosis is usually preserved in both ventricles, the systolic function. And we can see in this case, the right ventricle is dilated because it never recovered subsystemic pressures. So since birth, it always maintained systemic pressures, and it can also show signs of hypertrophy and trabecular hypertrophy, like in this case. So what are the variants of tetraloopholothis? So some have been mentioned in the previous talk, but basically we need to take into consideration that any kind of ventricular septal defect can happen, but most of the time is perimembranous, and double committed can happen in 5% of the cases when the infundibular septum is absent. So then there would be continuation between the aortic valve annulus and the pulmonary valve annulus. The pulmonary stenosis can happen at any level and very commonly is combined. The pulmonary arteries can have abnormalities themselves. They could be small, or they might be an absent right or an absent left, or sometimes even they can be slings of one of the pulmonary artery branches coming off the other artery branch, or sometimes they are disconnected and supplied by the PDA, or even by the lungs would be supplied by MAP gas, so collaterals. So we need to try to see if they're convergent and if they are present in every patient that we scan. Then abnormalities of the aorta can happen also at different levels. The most common is the right aortic arch, which happens in approximately 25% of the cases and is most commonly seen in patients with DiGeorge syndrome. And the anomalies, the coronary arteries can be anomalous, particularly in their origin. And the most common is the LAT origin from the right coronary artery, which can affect 3% of the cases. And we're going to see examples of this. So in this case, this patient has tetraloopholothis and a double committed subarterial ventricular septal defect. So we can see here the aortic valve has continuation with the pulmonary valve, and there is no subinfundibular septum, and the same we can see in the angiography. So how would the stenosis look at the different levels? So apart from the pulse Doppler, we can use the continuous, and the continuous Doppler would give us, as you know, the peak velocity across all structures, but also the shape of the continuous Doppler itself would give us some clues to differentiate whether it's valvular, supravalvular, or subinfundibular, or infundibular, subvalvular. So usually subvalvular stenosis, like in this case, combined with valvular stenosis, would have a double shape. So the subvalvular stenosis would be dynamic for obstruction of the muscle in systole. So we would see the duck shape velocity here. And when it's a fixed stenosis, the Doppler flow would be more rounded and very dense. So it would be throughout the whole systole, would have a an earlier peak than the dynamic obstruction. And we can see in this case, this patient had both. However, in this other case, the obstruction was mostly at the level of the pulmonary valve, and also the supravalvular area is small. And in this case, we don't see double shape. We only see one that is predominantly rounded and with an earlier peak than the other case. So this suggests that it's a fixed obstruction. So the pulmonary valve itself can be abnormal, it's often dysplastic, sometimes can even be bicuspid, and it can be very small. So we need to see, and we have to tell the surgeon how the pulmonary valve is like, so that he can plan whether he's going to preserve it or not. And the pulmonary arteries, as I mentioned before, can have different abnormalities. So the most important view to see them is the suprasternal views with the bifurcation next to the aorta. We can see the right pulmonary artery and the left pulmonary artery in this baby that had normal size. And in this angiography, you can see a case of a child that actually had very abnormal pulmonary arteries with a very small hypoplastic pulmonary trunk, then flow predominantly directed to the right pulmonary artery causing dilatation, and then the left that was stenosed at the origin. The coronary artery anomalies, as I mentioned previously, are affected mostly at the origin, but sometimes, very rarely, could be also stenosis associated to the osteums. But the most frequent abnormality encountered is an origin from the right coronary artery of the left anterior descending coronary artery. And this has important implications for surgery because the left anterior descending coronary artery has to cross towards the a left ventricle and across the right ventricular flow tract to reach its normal territory of irrigation. And therefore, the surgeon, if he's going to do a ventriculotomy or cut across the infundibulum of the right ventricle to put a patch, it can accidentally dissect or affect the left anterior descending coronary artery and cause an infarct on this baby. So it's very important that we always detect this abnormality. And if we have any doubts with the echo, always try to do a CT scan to make sure that we rule out this. And to see the coronary arteries, well, children have much better window than adults, but basically we need to optimize as much as possible our window. And we will do that using high frequency transducer and lowering the Nyquist limit. Other coronary artery anomalies that have less clinical implications, but can also happen are, for example, the origin of a dual LAD. So the LAD would originate at its normal position, but there would be an accessory LAD crossing the outflow tract, and also a single coronary artery. In this case, it's very similar to the previous, with the difference that the circumflex is not having an independent origin, or a single coronary artery originating from the left ostium. And the abnormalities of the left arch, the most frequent is the right aortic arch, as we said, but also aberrant subclavian arteries can happen, and also very infrequently a double aortic arch. And previously, many patients who developed early cyanosis before the estimated ideal age of repair, which was 6 months, underwent shunts. And those patients had the shunt done between the aorta or its branches and the pulmonary artery branches. So it was especially important to assess the anatomy of the aortic arch and its branches for patients that were going to have shunts. Nowadays, we go more for percutaneous interventions, as we're going to comment in this talk. In this view, I can show you the bifurcation of the aortic arch, or the first branch of the aortic arch, the subclavian artery on the right, the left carotid, pointing towards the left. So that would be a left aortic arch. And then when it points towards the right, would be a right aortic arch, like you can see in this view. So this baby has a right aortic arch with a bifurcation pointing towards the right. And patients with Tetraloopholothis, depending on the degree of pulmonary stenosis, can also have additional sources of blood supply. As it was mentioned, it is more frequent in cases that have extreme pulmonary stenosis or pulmonary atresia itself, But PDA is actually not uncommon, especially in the first days of life, and some of them can also have collaterals, but mostly patients with pulmonary atresia. So the different variants of tetralogy are considered now a different spectrum, and they include, as it was also mentioned in the previous talk, pulmonary atresia with patent duct, the variant of the absent pulmonary valve syndrome, the pulmonary atresia with systemic collaterals, so double outlet right ventricle. So this case, for example, demonstrates that the aortic overriding is committed to the right ventricle more than 50% of its length of the aortic valve, and therefore this case is not tetralogy by definition, but it would be a double outlet right ventricle or a TOF-like double outlet right ventricle. So double outlet right ventricle with subaortic VSD would be the most accurate classification. And in this case, also the mid-aortic continuity is lost. This is not the case of an absent pulmonary valve syndrome. So going back to the subcostal view, the anterior oblique view shows a subaortic VSD in a very similar position of the tetralogy, but in this case, the pulmonary valve leaflets are rudimentary, and there is severe pulmonary stenosis plus severe pulmonary regurgitation with an aneurysmatic dilatation of the pulmonary branches and pulmonary tract. Additional defects can happen in patients with tetralogy, and it's important that we detect them all so that they could be corrected at the time of surgery, and also so that we can understand exactly how the child is behaving, because they can interfere with the clinical presentation. So for example, having a secundometrial septal defect would increase the amount of shunt from left to right, or if there's severe stenosis and in very extreme cases, it could even shunt right to left, or even in very, very young babies, it could still shunt bidirectionally. And it's present in approximately 10% of the tetralogy, and the combination with tetralogy and ASD is called pentalogy. Then additional muscular VSD, some of them could be small and only seen after the main VSD is corrected in postoperatively, in which case we will modify the relationship of the pressures between the left and the right ventricle. So with a non-restrictive VSD, the pressures would be the same, but as soon as we close the non-restrictive VSD, then the pressures in the right ventricle would be lower than in the left ventricle. And therefore, if we have an additional ventricular septal defect that is small, we can see left-right shunt across an immediate post-op period. So it's important that we look for them in theaters after every surgery. Then tetralogy can be combined with the atrioventricular septal defects. It's not very common, but it can happen, especially in patients with trisomy 21. We need to seek for straddling of the tricuspid valve. That is not very frequent, but it's not impossible. And in that case, the biventricular repair would be much more difficult, or sometimes even impossible. Left-sided obstructional lesions are not very common, and left superior vena cava can happen in approximately 10% of the cases, but many of the conditions can happen. So it's very important that we do all our assessment in a systematic way, and we don't leave any structure unassessed. And these are several examples of tetralogy associated with, in this case, a complete atrioventricular septal defect with a Rastelli type C. In this case, you can see the straddling of the tricuspid valve with insertions on the left side of the septum. And this patient had an additional apical muscular VSD that in this case was not small. So echo plays an important role, but it's important not to check just the features of fallout, but all the presentation and all the structures. How will the baby behave when he's born? So basically, at the beginning, the baby will have a murmur, and then he will develop progressive cyanosis as he grows. And then the amount of cyanosis will depend on the amount of RVOT obstruction. So babies who have very severe RVOT obstruction will have bidirectional shunt across the VSD, but with predominantly right to left. And in this case, they can have cyanosis or progressive cyanosis, and even cyanotic spells, which would be secondary to shunting, basically, of the shutting of the RVOT, of the muscular RVOT, when there's severe obstruction, and the case can deteriorate or even lose consciousness if this happens by losing, by severe cyanosis and losing output on the right ventricle. But babies who have not that severe pulmonary stenosis, the large VSD would facilitate left to right shunt predominantly, and then these babies could develop heart failure by volume overload to the lungs, but this is very uncommon. And there are cases when the proportion of shunt left to right across the VSD and RVOT obstruction is compensated, and those babies are called well-balanced or pink cyanotic tetralogy fallout, and they can last longer until their definitive repair. So the important things that we need to take into account for surgery is the baseline saturation of our patient, how cyanosed he is, what's his weight. If he's very small, he cannot undergo complete repair, and we need to do something before, even even either a palliative shunt or a palliative percutaneous intervention. Then we need to always assess the degree of pulmonary artery hypoplasia, and if there are anomalous coronary arteries, if there are additional sources of pulmonary blood supply, and if there are intracardiac cardiac lesions. So all of this, most of it can be assessed by echo, but we need to also put it in context with the clinical status of the child. So years ago, and in some countries still to date, a systemic to pulmonary shunts are the preferred option to palliate the patient until he grows enough to undergo surgery. So usually these are done if the baby is very cynosed before the year, before 6 months of age. And there were different types of shunts that basically all of them created a left to right shunt, so from the aorta or one of its branches into the pulmonary arteries. So the blood thoracic shunt was classically connected by enteroside anastomosis of the subclavian artery to the pulmonary artery, but it has been demonstrated that this caused pulmonary hypertension over time. So the modification that's been done more recently includes an interposition graft between the subclavian and the PA. Then the Watterson shunt basically is a connection between the ascending aorta and the right pulmonary artery, and the POTS would be a connection between the descending aorta and the left pulmonary artery. But these are currently not used nowadays because we know that they are given a long time pulmonary hypertension, and we have much better options nowadays. So this is how they would look like in a schematic representation. So the classic PT shunt connected directly to the PA. Then the modified with an interposition graft and the Watterson and the POT shunts at the level of the ascending and descending aorta, respectively. Having a previous shunt has to be corrected at the time of surgery, so it has to be taken down, but it can leave also sequelae. So the pulmonary artery branches can be distorted after the shunt had been inserted, and the patients can have problems with that during the future. So it's important always to check for stenosis or abnormalities in the branches of patients who had a previous shunt. And this is an image of a patient with a modified PT shunt. So from suprasternal views, at the level of the left subclavian artery, we can see a shunt that is continuous left to right, and it has high velocity. So in this case, it suggests that the shunt is patent, and also that pulmonary artery pressures are not increased because the left to right shunt has high velocity. Okay, but nowadays, as I mentioned, we have other options that are a bit more attractive, and they are basically percutaneous interventions. So what we are doing, at least in my center nowadays, is to stent either the RVOT or the PDA while the baby is small, if he's severely cynosed, and then that would allow the child to grow until he can undergo full repair when he's approximately 6 kilograms or 6 months of age. So basically, the RVOT is stenting uses, as well as the PDA stenting, coronary stents. So there are no dedicated stents to date. Some of them will need repeated intervention. Some patients who have RVOT stenting might not have enough supply of blood to the lungs, and then maybe a PDA stent might be needed on top of the RVOT stented, or the opposite. But it is usually a safe technique, and it can help maintain much better saturation and also favor the growth of the pulmonary arteries by facilitating this anterograde flow through the RVOT. Whereas the PDA stenting is usually preferred in patients who have still patent ductus arteriosus at the time of the severe cyanosis. And it could also prevent the growth of the pulmonary arteries, but less likely than in the RVOT stented. So we prefer usually the RVOT stented if the pulmonary artery branches are small, because, as I said, it favors better the growth of the pulmonary artery branches. And we can see here a case of a child who had very severe RVOT obstruction that was stented, and then a bit turbulent flow, because the stent is not very, very big, but actually providing enough flow to ensure a forward flow to the branch pulmonary arteries. And this is a case of a child who underwent a PDA stenting that usually is inserted through an arterial access, either peripheral or through a carotid. And the PDA stenting, the problem is that it could migrate into the pulmonary artery, the left pulmonary artery, or it could even protrude into the aorta. So it could cause a stenosis of flow in the left pulmonary artery or the aorta. So the echo is very important in every patient who has had stents, either in the RVOT or the PDA, to ensure that it's in the right position, that it's not causing obstruction of surrounding structures, and the flow is patent. And if our child desaturates abruptly after either of these interventions, the first thing we need to do is to go under scan to make sure these are patent. Then once our baby is big enough to undergo complete surgical repair, he would go the classic repair of Tetraloopholothis, which would be basically a patch closure of the ventricular septal defect, then resection of the muscle bundles that are in the RVOT obstructing the subinfundibular area, the subpulmonary area, and then a patch repair that could be extended across the pulmonary valve or not, according to how small and how affected the pulmonary valve is. And in children who have anomalous coronary arteries crossing the RVOT, like the anomalous LAD coming from the RCA that I mentioned previously, will need a conduit to bypass that area, so we cannot risk damaging the LAD, putting a patch or doing an infundibulectomy across the area where the LAD is crossing. And sometimes also when the repair of the Tetraloopholothis is performed in older children, we could put human homograft or xenografts straight away instead of a patch, because they would tolerate much better an homograft size that is reasonable and would have less risk of developing pulmonary regurgitation. So classically, the repair of Tetraloopholothis has been performed through a transventricular repair, but we know that transventricular repair leaves scars in the ventricle that could promote arrhythmias in the future. So in the late years, the transarterial repair combined with also transpulmonary transection is the most favorable one, but it depends a bit on the institution and the experience of the surgeon. So the both of them have advantages and disadvantages. The transventricular repair might be more comfortable, but the transarterial repair does not leave scars in the ventricle, so there's less risk for arrhythmias in the future. So that's why we prefer it nowadays. And the favorable anatomy for repair would be that the child has ideally well-developed main pulmonary artery and branches that are confluent, there are no coronary artery anomalies, and that there are no additional ventricular septal defects. So echo can detect all of that. And this is another example of a child who had an anomalous left anterior coronary artery or an accessible left coronary artery from the right coronary artery crossing the RVOT. And in this case, we have inserted a pulmonary artery, right ventricular to pulmonary artery conduit that I will show you in this video. It's much more anterior than we would expect, but in this case it's working well, and you just have to be aware when you do the scan that this patient might have two outflow tracts. So if we put a conduit between the right ventricle and the pulmonary artery, we sometimes leave the native outflow tract and then we put the conduit on top of it. So if you do an echo and you see an outflow tract that is severely stenosed, it doesn't mean that the conduit is severely stenosed. It means that your child has two outlets. So you need to be very careful with that. And I recommend that you always go to the surgical notes before doing a scan on the patient for the first time. So just very briefly, what can intraoperative TOE provide? So it can help confirming the diagnosis and ruling additional defects that might have been overlooked in a transthoracic echo. It could also assess the immediate results post-repair, and is also useful to monitor percutaneous interventions. So the anatomy is confirmed and similar than the transthoracic echo. So basically overriding aorta with large subaortic VSD, right ventricular hypertrophy with dilatation of the ventricle from different views. This is a midesophageal apical A5 chamber, and this is a midesophageal long axis view. Then in the short axis view, midesophageal, we can see obstruction of flow at the subalveolar level with acceleration that starts much earlier than the pulmonary valve. And then we can put continuous Doppler here, or even through subcostal views, and also across the VSD that would be shunting bidirectionally. And this is a video of an RVOT in a patient with Tetraloopholothis with a modified short axis view. And we can see that the muscles actually collapse and cause severe obstruction. And this is a short axis view showing the origin of the left coronary artery from the left coronary cusp in its respective position. So it's important that you always look for that if you're going to operate across the outflow tract of the right ventricle. But the TOE has blind spots, so the arch and the branches cannot be very well seen. The left pulmonary artery is normally not visualized because of interference of the bronchi. Also, the ductus cannot be assessed, then some palliative connections cannot be monitored or confirmed to be patent postoperatively, and we cannot see the collateral. So the TOE is good, it gives additional information, but the TTE remains indispensable. And this is an example of a upper esophageal view of the main pulmonary artery with the right pulmonary artery, but we don't see the left pulmonary artery. And this is not the case with a small right pulmonary artery that we could catch here, but we don't see very well the main pulmonary artery or the left. So these things have to be assessed preoperatively. And immediately post-repair, the most important things that we cannot miss are the residual obstruction across the RVOT, the degree of pulmonary valve regurgitation, if there are residual ventricular septal defects, or if there's a leak across the ventricular septal defect patch, the size and function of the left ventricle, the size and function of the right ventricle, and also the tricuspid and aortic valve function, which can be both of them damaged by the Vsd patch at the time of the repair and the stitching of the Vsd patch. So we always need to confirm that when our child comes out of theaters, all these things are reviewed, so we know that the surgery has been successful. And then percutaneous interventions can also be needed before the surgical repair. So if we put an RVOT stent or a PDA stent, we might need to intervene on the pulmonary branches if they haven't grown enough with the anterograph flow, or even put in a second stent over the PDA, or the RVOT in a patient who has had a stent on the other side, or even a stent into the RVOT stent if this has become narrowed or stenosed. And post-surgical repair, percutaneous interventions might be also important in early life to close additional collaterals that were remaining after surgery, or to also treat post-embolic pulmonary artery stenosis or postoperative pulmonary artery stenosis, or if there has been occlusion of any of the branches postoperatively, or things like that. So echo plays a very important role in evaluating the results immediately after surgery, but also during the first months to reassess if the child needs a second intervention before adulthood. And now going to the second part of the talk, we will talk about the echocardiographic assessment of tetraloopholothis post-repair, but more focused in adults. So most adults that we see now in clinics have already undergone surgery during early life, either palliative or reparative, and TT remains the first-line imaging technique during follow-up. Even in adults who have, or early adults or teenagers who have not had repair of tetraloopholothis, we could still consider full repair of them, provided the pulmonary artery pressures are not increased, and the pulmonary artery stenosis, the pulmonary valve stenosis, or the infinibular stenosis protect the lungs against developing pulmonary artery pressures, but you have to take into consideration that there might be collaterals if the patient was chronically stenosis that could have provided additional flow to any of the lungs and increase the pulmonary artery pressures in both lungs or even segmentally. So it's very important that if you have a child that, or a teenager or an early adult that has not been repaired in early life, is properly assessed, and hopefully in most of the cases undergoes a cath to confirm that pulmonary artery pressures, and then can undergo the repair. So the echo must assess residual lesions, the most important being pulmonary regurgitation, RV dilatation, and dysfunction after the complete repair of tetraloopholothis. Acquired lesions that could be sometimes associated to the type of repair or to the natural history of the tetraloopholothis, or even acquired diseases during life, like for example, acquired coronary artery disease or acquired mitral valve disease. We need to always to pick it up. And then the hemodynamic consequences of everything. And guidelines about postoperative echo monitoring of patients with tetraloopholothis have been published. This is a very good paper published by the American Society of Echo in 2014. And this table summarizes the basic features that we need to see. So problems inherent to tetraloopholothis repair, like for example, would be the residual RVOT obstruction or the Vsd patch integrity, then residual lesions, for example, if there's a leak across the Vsd, or if there's an initial septal defect that was not closed during infancy, or if there has been recurrence of RVOT obstruction, then acquired lesions at the time of surgery or secondary to dilatation of the ventricle. If our patient has, for example, severe pulmonary regurgitation, he can develop also tricuspid valve regurgitation, so we need to assess all of that. And then other anomalies at the level of the coronary arteries or the aorta. And the functional abnormalities are all the hemodynamic implications. So volume overload caused by any valvular regurgitation or by residual shunts, pressure overload by residual obstruction, or in cases with pulmonary hypertension, for example, even if we don't have residual RVOT obstruction or pulmonary stenosis, we might have increased pressure load to the right ventricle for residual pulmonary hypertension, for example, or diastolic dysfunction of the left ventricle that might increase the pulmonary artery pressures and then increase the pressures on the right side. Also, problems on the left side that could be acquired, like progressive aortic regurgitation for aortic root dilatation, or problems secondary to arrhythmias. So the most important things that we need to see, obviously we need to reassess everything, but is the right ventricular size and function, the left ventricular size and function, the residual pulmonary stenosis and regurgitation, and the tricuspid valve regurgitation. And this is because these are the features that mostly have prognostic implications in patients with Tetraloopholothis. So pulmonary regurgitation is the most frequent reason for reintervention in our patients. And we know that it's almost always encountered in patients who have had a transannular patch repair. 1/3 of these patients with pulmonary regurgitation need a second operation in life, especially if the regurgitation is severe. And the regurgitation is deleterious because it causes severe chronic overload to the ventricle that then dilates and can become dysfunction in the late stage. And that reduces the exercise tolerance, prolongs the QRS, and favors arrhythmias and sudden cardiac death. So relying on the symptoms for deciding the timing of pulmonary bleeding, and the patient may become symptomatic at a very late stage when the right ventricle is already severely impaired or too dilated and may not remodel after surgery. So even if the timing for pulmonary regurgitation replacement, pulmonary valve replacement, is a bit controversial to date, it is important that echo checks its severity, its mechanism, and its progression in every scan. And if we see that it's becoming severe, we see the child or the adult more frequently in order to assess how the ventricle is functioning, because our patient might be completely asymptomatic until a later stage. So how would you differentiate if pulmonary regurgitation is mild, moderate, or severe? So mild, moderate regurgitation usually is brief and has small jet, not fulfilling most of the RVOT. And in Doppler, it has low velocity and lasts throughout the whole diastole. And then if we do a Doppler in the pulmonary arteries, we see no retrograde diastolic flow. Then moderate regurgitation usually can have a more steep deceleration, but it tends to last throughout the whole diastole. And if we do a Doppler in the pulmonary arteries, we may see some very brief retrograde flow in diastole, but severe pulmonary regurgitation usually ends before the end of diastole and is much more steep in its slope. And also the regurgitation can lead to retrograde flow in the main pulmonary artery or even in the branches. That is obvious not only on Doppler, but in continuous Doppler, but also in pulse Doppler or in color Doppler. So the color grading of severe pulmonary regurgitation, like in this case, for example, that we see this patient has a severely dilated right ventricle at the level of the outflow tract, almost aneurysmatic, and has very severe pulmonary regurgitation that fills most of the outflow tract. And we say that the jet width to RVOT ratio in diameter is mild when it's less than 1/3. So if the jet of the pulmonary regurgitation fills the RVOT in less than 1/3 of its size, of its diameter, we consider that mild. If it is up to 2/3, we consider that moderate according to color flow grading. And if it is more than 2/3 of the dimension of the RVOT, then we could say that this regurgitation is severe. In this case, you can see it's clearly severe. It's a very broad jet, also very long, reaching at the wall of the ventricle. And this is another example where you can see retrograde flow in diastole in the main pulmonary arteries and branches. This red flow here is retrograde flow in diastole. So that reversal flow suggests that the amount of regurgitation is severe. There are different parameters that could help us quantify. So the qualitative parameters of severe regurgitation are a good indication, but we try to quantify as much as possible, especially if we are going to compare it in follow-up. And several indices have been described to have a very good correlation with the ejection fraction, the regurgitant fraction in MRI. So the pressure half time across the pulmonary regurgitation Doppler trace of less than 100. So it means if the slope is quick, so if it decreases its pressure quickly, so if it is steep with the pressure half time of less than 100, then it's more indicative of a regurgitation fraction by MRI of more than 25%, which would be severe. And the PR index is the relationship between the duration of the PR and the whole diastole. So if we measure the duration of the PR until it ends, and we do a ratio of that divided by the whole duration of the diastole, we get an index, which is the PR index. And if this is less than 0.77, we know that it is correlated with severe regurgitation in MRI. So it's important we do that also with every case. And what are the consequences of severe pulmonary regurgitation or volume overload? So though they contribute to right ventricular dilatation and dysfunction, but there are other reasons of the right ventricular dilatation post-tetraloopholothis repair, like for example, a residual obstruction when it's very severe and very long lasting, or previous scars across the ventricle, so previous transventricular incision. So in this case, for example, we see in the short axis a right ventricle which is dilated because it occupies most of the space here. It's not like a moon shape, it goes all around like almost like an old clock. And in this view, you can see clearly severely dilated and is pushing the septum of the left ventricle. I think it was already in systole. In the 4-chamber views, we can measure the dimensions of the ventricle, and the guideline says that any ventricle that has a basal diameter more than 42 or a mid diameter more than 35 or even more than 86 longitudinal diameter is dilated. And then qualitatively, you can compare with a left ventricle, and you can see that in this case, the right ventricle is apex forming and also is bigger in size than the left ventricle. So this ventricle is severely dilated. But also you have to bear into account that sometimes the right ventricle might not be that dilated in the 4-chamber view, but can have an aneurysmatic dilatation of the RVOT, that is where we did the previous patch repair. So you have to assess the ventricular dimension of the right ventricle in all views and then leave at global estimates. And we know that the right ventricle that dilates very much might not recover fully after correction of the volume overload if the cause that could be contributing to the dilatation is volume overload, for example, in cases of severe pulmonary regurgitation. And some studies have suggested that when the right ventricular end diastolic volume is more or equal to 160 mils per square meter or more than 80 mils per square meter in systole, in MRI, that normally indicates that the ventricle will not be able to remodel after the pulmonary valve replacement. And it has been suggested that a right ventricular end diastolic area from apical views of less than 20 correlates with a right ventricular end diastolic volume of less than 130 milliliters per square meter in MRI. So that would be more or less the target that we could analyze in our 4-chamber views. But as I said, the echo is very interesting, but it's not the only imaging technique that contributes to assessment of the tetraloopholothis, and magnetic resonance becomes more important in repair phallotes for the estimation of the exact volume of the ventricle and also of the exact function. So in this case, the applications of echo are a bit limited to predict which ventricles are going to remodel and which are not. But it has been suggested this correlation with MRI. And then RV dilatation, we know that can favor the development of ventricular arrhythmias and then sudden death. And also the ECG can be of value to estimate how big the ventricle is or whether it is progressing, because it has been correlated prolongation in the QRS duration of a follow-up with prolongation or dilatation of the right ventricular measurements. And we know that when the QRS becomes more than 180 milliseconds, then or when it increases very quickly, there's increased risk of ventricular tachycardia or even sudden cardiac death in our patients. And the tetraloopholothis patients who have been repaired have an estimate of 0.5 to 6% over 30 years risk of sudden cardiac death. So ventricular dilatation is important. It's important that we correct the pulmonary regurgitation before the right ventricular size is irreversible. And also we need to look at other parameters if there are doubts of whether the right ventricle might be dilating or not. Regarding the systolic function of the right ventricle, so the longitudinal parameters are usually affected after surgery. So the TAPSE and the S-wave can be slightly reduced in patients with tetraloopholothis, but we know as well that some of the tissue Doppler parameters are volume dependent. So they are not very reliable in patients with tetraloopholothis to give like a cutoff of normality. But what we can say is that we can compare the patient with himself during follow-up to see if this is decreasing, and that would be a sign of deterioration of the ventricular function. Also, the fractional area change could be monitored and compared in follow-up. We need to be also aware of the regional wall motions and abnormalities that can affect the right ventricle. So maybe we have a good fractional area change in the 4-chamber view, but then our short axis view shows that the RVOT is completely aneurysmatic and very dilated, so we cannot say that the function is normal regardless of the fractional area change. So those are the limitations of echo 2D echo. So some studies have suggested that 3D could play a role in the estimation of the right ventricular volumes and function in patients after Tetraloopholothis. And this is a study published in 2011 in JASE, but other more recent studies suggest that it can have promising applications in patients with Tetraloopholothis. The problem of these studies and of 3D in Tetraloopholothis is that it has not demonstrated to be superior to the estimation of the volumes and function by CMR. So that's why they are not standardized techniques to date, but they are fields for further research in the future. And then this is an example of a patient who had, right ventricular dysfunction after Tetraloopholothis repair. So we can see that in this case, he had residual hypertrophy of the right ventricle that did not recover, possibly due to residual obstruction. And also this paradoxical motion and desynchrony, intraventricular and interventricular. So this case, for example, this patient has a very bad function of the ventricle, we can see. And the causes of systolic dysfunction of the ventricle can be multifactorial. So it could be due to the hypoxia, the chronic cyanosis before birth, or before repair, or even the chronic pressure overload before repair. Also, consequences of the ventriculotomy or the muscle resection, coronary artery problems, then inadequate myocardial protection during the intervention, or if our ventricle is very hypertrophied, there might be microvascular ischemia, because maybe the right coronary artery might not be enough to perfuse all the muscle. Also, as well, so any kind of a stress of pulmonary regurgitation, especially if combined with residual RVOT obstruction, can give, on the long term, more systolic dysfunction to the ventricle. And the ventricle, the right ventricle, can be affected not only in the systolic function, but also at the restriction. So the diastolic function can be abnormal. And it has been proven that diastolic dysfunction in the Tetraloopholothis is present early in life, also after late repair, but it is in many cases already present early in life. And we don't know exactly the cause. There might be multifactorial as well. And the hypoxia and cyanosis can play a role as previously. Also, the type of repair. It has been suggested that patients who had transannular repair had more severe degrees of obstruction because the pulmonary valve was abnormal as well as the subinfundibular area, and therefore those patients could have been more exposed to pressure load than patients who did not require transannular patch. But actually some studies have not confirmed that restriction was present only in patients with transannular patch, because patients with no transannular patch also developed restriction during follow-up. So it might be one contributing factor, but it's not a single explanation that could be sufficient for this physiology. And also the type of surgical repair. So it has not been confirmed whether transaxial or transventricular repair could be more protective or not against restriction. It is suggested that maybe transaxial approach could be beneficial, but it's not fully proven. And also, please bear in mind that the right ventricle might have also fibrosis in some areas. So that ventricle would be more stiff, more prone to impaired relaxation. So how is it assessed in transthoracic echocardiogram? So the restriction has different parameters, but the most reliable one is the prehistoric K wave. This is basically this anterograde forward flow that we can see just before the quarters and before the systole of the ventricle. So it has been confirmed that this prehistoric K wave basically corresponded to the right ventricular diastolic pressure that equalized or exalted basically the PA diastolic pressure. So that means that in diastole, when the atrial contracts at the end of diastole, the pressure in the right ventricle might be already equal to the pressure in the pulmonary artery, and therefore this extra kick of the atrium may be sufficient to provide some forward flow across the pulmonary artery, even if it is no time for the pulmonary valve to open, just because the right ventricle is stiff and cannot accommodate that extra flow. So it's important to see in our echo if there's a prehistoric A wave, in which case we can confirm a ventricle is restrictive. And this is another view of a prehistoric A wave consistently before the QRS and at the time more or less of the P wave corresponding with end diastole. And what happens when the patient has severe pulmonary regurgitation, where if we have severe pulmonary regurgitation, then the ventricle will reach high pressure in diastole quicker than if the patient has no pulmonary regurgitation or no severe pulmonary regurgitation. So if our ventricle is not only volume loaded, but also pressure loaded or restrictive, then the duration of the PR might be shortened, because when the ventricle has the HR kick at the end of diastole, then it can interrupt, let's say, the degree of pulmonary regurgitation and then provide some forward flow. And it has been suggested that this forward flow at the end of the diastole, shortening the duration of the pulmonary regurgitation, might be beneficial in terms of symptoms by improving exercise capacity and cardiac output. But we know from recent studies that actually having a restrictive ventricle is not beneficial in the long term. Another clues to assess restriction of our ventricle would be, for example, if our ventricle is very stiff and may not dilate during follow-up, we could monitor the size of the right atrium. So if we see a ventricle that is thickened and is not dilating over time, but the right atrium is dilating in the absence of tricuspid regurgitation, then we can suggest that the right ventricle has high pressures and diastolic dysfunction, and this is a dilated right atrium secondary to dilated right atrial pressures. And in echo, an end-systolic area of the right atrium more than 18 centimeters, so it's considered dilated. But it's important, as I said, that you compare the echo sequentially during follow-up to see if this is getting worse or not. And also a dilated right atrium and restrictive physiology would favor the development of atrial arrhythmias in our patients, which actually can affect to 20 to 25 or even 25% of patients with tetralogy of Fallot. Then sometimes if the right atrial pressure is very high and the patient has TR, we can see retrograde flow in the vena cava, even if the tricuspid regurgitation is not severe, just because the right atrial pressure is so big and so elevated that it cannot accommodate the extra volume from the tricuspid regurgitation. So we would see retrograde flow into the caval vein, even if the TR is not severe. And it has been suggested that restrictive physiology in the right ventricle could be assessed by transmitral transtricuspid inflow Doppler, and that would reflect a short deceleration time of the E wave and also an EA relationship of more than 2. But we know that the transtricuspid inflow and the Doppler is influenced by volume conditions as well, so might not be always reliable. But if we take all these parameters into account, we could very easily see if our patient is restrictive or not. Then other things that we always have to assess in our repaired patients are the degrees of RVT obstruction and the levels. Yes, so in this case, subpulmonary would be dynamic with a late peak and duct shape of the Doppler. In this case, the patient had a peak gradient of 100 millimeters of mercury, so very severe residual pulmonary stenosis or recurrent pulmonary stenosis. And in this case, this tracing shows a more rounded shape with an earlier peak of the high velocity, suggesting there is a fixed obstruction either at the valve level or in the main pulmonary artery. However, sometimes there could be peripheral pulmonary stenosis or pulmonary stenosis in the branches or branches that have been kinked or distorted by previous shunts that we cannot see by Doppler at the level of the pulmonary artery. So an indirect estimate could be the velocity across the tricuspid valve. So here, the tricuspid valve, in the absence of significant residual infundibular or valvular pulmonary stenosis, could reflect the right ventricular and systolic pressure, and in this case was high, and our patient had peripheral pulmonary stenosis. So peripheral pulmonary stenosis would increase the pressures in the lung, in the right ventricle, and in the absence of stenosis at other level, that could be assessed by the tricuspid valve velocity. So this patient had very tiny tricuspid valve jets, but the regurgitation was enough to estimate a severe residual gradient. And the tricuspid valve itself can be regurgitant, not for pressure overload or pulmonary artery pressure. So it means when the right ventricle is still pressure loaded by residual pulmonary stenosis or pulmonary artery pressure or peripheral pulmonary stenosis, then the ventricle can dilate or the atrium can dilate, and then the tricuspid can dilate and leak, and that would be functional tricuspid regurgitation. But there are cases in which the tricuspid regurgitation is caused by damage of the tricuspid valve at the time of repair, especially when we put the Vsd patch. That's why I insisted during the intraoperative theory that we should assess how the tricuspid valve functions immediately post-surgery. And also there could be acquired disease of the tricuspid valve during follow-up, like for example, tricuspid endocarditis, or our patient might have had an ICD inserted for primary secondary prevention, and that could have led to tricuspid regurgitation. So it's very important to assess the presence, the severity, and the mechanism of pulmonary regurgitation. And sometimes when it's very bad, the patient might need an intervention on the tricuspid valve, like in this case, this patient needed a tricuspid valve replacement with a mechanical valve. Yes, and we know also in patients with Tetraloopholothis that the Vsd patch can leak, or it can even get infected by endocarditis. So we always have to have a very close look at it. And in this case, for example, we see it in the parasternal long axis, like an echo-bright structure in between the right ventricle and the aorta, well, in the LVOT, just before the aortic root. And also we can see it very well from the apical 5-chamber view, and we can put color on it to detect if there's any leak. And this is an example of how the Vsd patch will look like. So you can see it's distorting the shape of the Vsd and it's more echo-bright, just below the level of the aortic valve in between the LVOT and the right ventricle. And this is an example of a patient who had a leak across the Vsd. As you can see, it's shunting left to right. And it's important that we estimate the velocities across to see exactly if it is restrictive or not, because if there's a residual leak that is important, it might need intervention because it would create a left to right shunt. So if there's a cubic ES of more than 1.5 across the shunt, residual shunt in the VSD, that would be an indication for repair, regardless that it is a reduced surgery. So it would be the same indication as pre-op. And regarding the left side of the heart in Tetraloopholothis, we know that tetralogy was mostly a right-sided disease, but actually repair patients can develop problems on the left side, and the most important is the LV dysfunction, which can have prognostic implications. So in this case, we can see a left ventricular function, the systolic is preserved, but there's some paradoxical septal motion of the septum. Sometimes when the RV is very dilated, there could be pushing of the septum towards the LV that is so bad that it could cause dysynchrony or even impair the filling of the left ventricle. So it's very important that we check the possible etiology of LV dysfunction. Sometimes it's unclear, and sometimes it can be multifactorial, but some of the proposed causes are long-standing cyanosis pre-repair, chronic volume overload from left to right shunts across the VSD or across the palliative shunt, then inadequate myocardial protection at the time of surgery, injury to the left coronary artery at the time of repair if it was undetected, residual ventricular septal defects, asynchrony, as I mentioned, or even severe RV dilatation or dysfunction. And the aortic root can also dilate during follow-up in patients with Tetraloopholothis, and we have seen that actually the root of the patients with Tetraloopholothis and ascending aorta are not normal in structure. So some histological studies have demonstrated that there are some abnormalities in the components of the aortic wall. So they might be more prone to dilation. However, some studies performed in our center confirmed that the risk of dissection is actually very low in patients with Tetraloopholothis. And the current recommendations are that we follow the same criteria for general population for operating aortic root dilatation according to its size and also to the secondary degree of aortic regurgitation that can happen. And obviously, the risk of endocarditis is always present in any patient with cyanotic congenital heart disease, and post-repair, the risk remains, especially if our patient has a valve inserted or a conduit. So it is very important that we always try to rule it out if our patient behaves clinically as if he could be infected. And we see here a patient with pulmonary valve replacement that had flickering structure in one of the leaflets, very suggestive of pulmonary endocarditis, pulmonary valve endocarditis. Sometimes the vegetations can also be obstructive and cause increased gradients, and sometimes they can also form along the conduit itself or the main PA or previous suture lines and not in the leaflets. So you have to be very suspicious and take into account that even if you don't see anything flickering into the RVOT, there might be something upstream in the main pulmonary artery or the conduit. So what are the indications for intervening our patient with Tetraloopholothis? So the most important has already been mentioned, is the pulmonary regurgitation in order to prevent dilatation, dysfunction of the right ventricle, and then the risk of arrhythmias and sudden death. Then in patients with symptoms and severe regurgitation, it is accepted that it's a 1C, and the transcatheter interventions are actually now the preferred options when anatomically feasible. But in patients who are asymptomatic, we have to take into consideration other things, like, for example, the volume of the right ventricles by MRI, or the exercise capacity to compare with previous exercise capacities of that patients in previous follow-ups to see if that is declining or not. Then progressive of RV dilatation, or even if the RVT obstruction if there's RVT obstruction combined with the regurgitation, or if there's pulmonary hypertension or very increased pressures across the right ventricle for any other reason. So the preferred option nowadays are not only surgical, but mostly transcatheter options. So we could do balloon angioplasty, we could insert a bare metal stent, or we can insert directly a valve. And that works for either stenosis or regurgitation, and that works also for patients who have had previous repair and conduits inserted, or for patients who have their own native outflow tract as well. The only limitation is that some of the valves previously used were quite small, and some of the patients with tetraloopholothis have large outflow tracts. So now we are using, at least in our institution, more Edwards valves than Melody valves, and also the risk of endocarditis, we are expecting it to be lower with the new valve than with the Melody. That was one of the most important complications this valve had during follow-up. This is an example of a patient who had severe pulmonary regurgitation after tetraloopholothis, who underwent a successful insertion of a Melody valve percutaneously, and you can see here there's no residual obstruction and no residual regurgitation. That it was a very good result in our center. And we say basically that it would be a good result if we see at most mild regurgitation, or if the gradient across the valve is less than 15. That would be the optimal result for a Melody valve. And the Melody valve or the stents can have problems during follow-up, as I mentioned before, the endocarditis, but also there could be stent fracture, there could be peripheral pulmonary stenosis that could progress despite correction of the valvular pulmonary stenosis, or also there could be subinfundibular stenosis that could be recurrent. So we need to always follow these patients and make sure that when we put a Melody valve, there is nothing else that needs repair at any other level, in which case maybe surgery would be preferred than a percutaneous procedure. So other interventions in patients with tetraloopholothis, this is a scheme from the last guidelines published in 2020 in adult congenital heart disease that summarizes the potential sources of problems in patients with previous follow-up. So the VSD can have a leak, and in that case, as I mentioned before, it should be corrected if it's causing volume overload, because it could impair further the function of the left ventricle, or even increase the pulmonary artery pressures then in follow-up. Then right ventricular flow tract might need resection of the aneurysm, or might need some ablation procedures as well at the areas where the scars are expected, or the previous infundendolectomy. And that is particularly important if you're going to insert a percutaneous valve, because if you insert a percutaneous valve, maybe some areas that could trigger arrhythmias in the RVT might not be accessible later for catheter ablation. So if our patient has risk of arrhythmias, or if he has already had arrhythmias previously, it's important that we try to ablate them before inserting a valve or doing surgical correction. Then aortic root repair or aortic valve repair, indications similar to general perforation, also as mentioned, tricuspid valve repair, at least with moderate tricuspid regurgitation, and can be performed at the time of pulmonary regurgitation, pulmonary repair replacement for pulmonary regurgitation. Interventions on peripheral pulmonary arteries are mostly percutaneous. Then atrial shunts might need to be closed if the patient has cyanosis, especially on exercise, or if he suffers an embolic event, or if they contribute to causing more volume load in patients who already have severe PR, for example, or other percutaneous procedures like ICD insertions, or even CRT insertion in patients with dyssynchrony. Some examples of intraoperative TOE for reduced surgery. So I think I showed already this picture of right ventricle that is severely impaired and severely dilated, also synchronous. This is a clip of a patient with a previous transannular patch that developed severe pulmonary regurgitation, as you can see, and he's going for redo a pulmonary valve replacement. This is the same patient from a subcostal view. which sometimes provides much better alignment than short axis or mid-esophageal views, as we can see in this case. So we can get a neat continuous Doppler to get the maximum velocity. And in this case, the stenosis was not very relevant, but the patient had severe regurgitation. This is another example of a patient who had surgery for severe alveolar obstruction, and we can see that the muscle bundles were resected, and now in the post-op there's laminar flow with no residual outflow tract obstruction. If we cannot get a good alignment from subcostal views or transgastric views or short axis view, we can go upper esophageal at the level of the main pulmonary artery and do a Doppler, and sometimes we can obtain very neat gradients by continuous Doppler. In this case, we can see that the results were good, and this patient does not have severe outflow tract obstruction. Also, the Vsd patch and the aortic valve function can be assessed very nicely from mid-esophageal views, both long axis and short axis. Yes, this is another view of the dilated aortic root. And then in this case, this is an example of a tricuspid valve that was restrictive and had severe central regurgitation. So the ventricle was stiff, and also there was restriction of the leaflets at the subvalvular apparatus. So with very dilated right atrium as well. So in this case, the patient underwent a tricuspid valve replacement, if I remember well. Then this is another patient who had a previous repair of the Tetraloopholothis, and we can see here the amount of tricuspid regurgitation in this case is very small, so he can undergo his pulmonary valve replacement with no need of treating the tricuspid valve. And this is a bubble test just to demonstrate that this patient had a residual shunt across the interlateral septum. Sometimes at the time of repair, a PFO can be created or left open just to prevent from increasing right atrial pressures in case of very restrictive ventricles. So at the time of redo, if we are going to operate exclusively on the right side and not put the patient on bypass, we need to make sure if there are shunts that could send some bubbles to the left ventricle and maybe emboli to the coronary arteries. So it's interesting always to do a bubble test before redo surgery for Tetraloopholothis, even if we expect to operate only on the right side. And this is another example of a patient who had a previous conduit at the pulmonary valve, and you can see a flickering structure here coming in and out that is attached to one of the pulmonary valve leaflets causing regurgitation, and this patient had infective endocarditis over a previous conduit. And just to finalize, I would like to mention that other imaging techniques become even more important than at the time of first repair, followed during follow-up, and before re-repair of the Tetraloopholothis. The MRI remains the gold standard for the right ventricular volumes and quantification of pulmonary regurgitation. It can also estimate the degree of QPQS when there are residual shunts present, and sometimes also can assess the degree of fibrosis in the wall of the right ventricle, even in the infundibulum. And that could give us an estimate of the risk of ventricular arrhythmias and sudden cardiac death of our patient and help us stratify the patient for an ICD, for primary prevention or for secondary prevention. Then the CT is still useful in coronary arteries, particularly in patients who are operated at an older age, which could have developed also atherosclerosis in the coronary arteries, but it can also check the lung parenchyma, and some patients may develop also lung disease during follow-up, so we can differentiate between lung disease and problems with the conduit or even branch stenosis. And also the cardiac catheterization, especially important in patients who are planned for late repair in life for the first time, but also for patients who might have residual peripheral pulmonary stenosis that could be treated percutaneously, and for patients who have severe pulmonary stenosis at the valvular level or severe pulmonary regurgitation, which are candidates for pulmonary valve replacement percutaneously. Yes, so just to conclude, echo remains the main imaging technique during follow-up, as well as the beginning of the assessment of the disease, as mentioned in the previous talk. Annual follow-up with echo is recommended in a specialist center, but it might be more frequent in patients with residual hemodynamic lesions or in case of clinical deterioration. Then the structural and hemodynamic assessment is necessary in every scan, as well as has suspicion for complications that may require additional imaging techniques, like for example, peripheral pulmonary stenosis or pulmonary hypertension or coronary artery disease in case of LV dysfunction. And then emerging echo imaging techniques like 3D or strain could have a useful contribution in patients with Tetraloopholothis, but the time is too early to make strong recommendations, and they have not proven to be better than MRI for the assessment of the volume and the function. So they need further development in this field. And that's all. Thank you for your attention.
Thank you, Dr. Verde, for the very brilliant presentation. It's quite a lot of material to speak about the tetralogy of the follow-up. But here is one question that is starting before the opening the session this evening. It's coming from abroad. What is the survival rate of the patient with the tetralogy of the follow-up? I think it depends from the clinical centers that we find it.
Yes.
Your opinion.
Yes, so I can share again the two first slides that I included. So the natural history of tetralopholothis actually carries very poor prognosis, and approximately 25% of the patients would die within the first year, untreated and without any kind of palliation, and approximately 95 of them die before 40 years of age. So actually, it's a disease that we need to treat, because otherwise our patients can die at a very early age, either in infancy or in young adulthood. So it's very important. And then I can share as well the second slide that I presented previously, just to show you that how treatment modifies the survival. So many patients can live many years with a shunt, but actually complete repair improves the survival very much, up to 85% at 35 years after the operation. And the downside is that our patients will need probably several interventions during life. And we know that when we put a pulmonary valve or an homograft, that would not last forever, and the patient might need replacement of that valve or that conduit several times. So every time we operate, there's risk of death, and there is risk of other complications, but the natural history of the disease is clearly much worse.
Thank you. Thank you for your answer. Goes we a little bit late. Professor Lee, do you have any comments?
Maria is so generous with her knowledge. You can see she has given every single details about follow to us. Thank you so much, Maria. Excellent talk, very comprehensive. I'm sorry for Professor Hristov. It's very late. I know in your site, it's people have to go to bed soon. So I have no questions anymore, but I hope people enjoyed Maria's talk. Thank you, Maria.
Thank you. Thank you very much.
Thank you. So we are going to the last presentation for this evening, and this will be my presentation about the congenital tricuspid valve abnormalities in echocardiography assessment. I will try to be very short, because many of the things was spoken before me, some of the tricuspid valve anomalies, but when we look at about the tricuspid valve in a normal heart, we know that the tricuspid valve has 3 leaflets, anterior, posterior, and the septal. And the conventional echocardiography, it's not possible to give us information about normal tricuspid valve, which is this is the posterior leaflets, septal leaflets, and this may be in the anterior leaflets here. So we can use in the nowadays the possibility to see the face the valve with the 3 leaflets when we're using the tricuspid 3D echocardiography, which is possible to analyze the anterior septal and the posterior leaflets and the hurdles, and how is going with the connection with the other structures in the right ventricle. So when we analyze the tricuspid valve, and we could mention how is the proportion with the another valves in the heart, the aortic valve, mitral valve, and the pulmonic valve, and how is going with the left ventricle outflow tract, the right ventricle outflow tract, and the inflow tract. Also, and the atriomitral curtain and the shape of the mitral annulus, and where is the AV node, and actually how is going with the coronary arteries, especially the right coronary arteries, and the coronary sinews. we could everything to search about in the patient. But this is the one normal heart with the 3D illumination with looking very well with tricuspid valve with the 3 leaflets, and here is also could see the normal valve with the connection and how is going with the obstruction for the outer mitral with the mitral valve especially. So the congenital anomalies could be found in the, especially is the Epstein anomaly, which is less than 1% of the all congenital heart disease. You can find also the tricuspid valve prolapses and the tricuspid valve dysplasia. It's very rare, but it's not uncommon. So Epstein anomaly is the congenital defects, which is malformation of the tricuspid valve and right ventricle characterized by the adherence of the septal and posterior leaflets, which is the underlying myocardium failure of the delamination, namely splitting of the tissue to the detachment of the inner layer during the embryonic development, downward apical displacement of the valve, displacement of the functional annulus, the septal posterior and anterior, dilatation of the atrium, which is atrialization, the portion of the right ventricle with various degree of the hypertrophy and thinning of the valve. Reducency, fenestration, also tightening the anterior leaflet. And the last one is the dilatation of the right anteroventricular junction, which is the true tricuspid annulus. The apical displacement of the hind point of the valve of the Epstein anomaly from the anteroventricular ring is shown in this figure, which is how this displacement is going back. The point of the maximal displacement is the commissure between the posterior and the septal leaflets of the tricuspid valve. In the normal human hearts, the downward displacement of the septal and the posterior leaflets in relation to the anterior mitral valve leaflets, it's less than 8 millimeter. But the spectrum of the malformation of the Epstein anomalies may range from the only minimal displacement of the septal and posterior leaflet is important of the membrane of muscular shelf between the inter and trabecular zone is going to be greater from 8 millimeter. Sometimes it's around 2 and 3 centimeter. The anterior leaflet is generally redundant and may contain several fenestration. Its heart tendinae are generally short and very poorly performed. So the main things that could find this is the origin of the septum posterior leaflets or both are displaced downward in the right ventricle. Leaflets are the variability of deformation, atrialization of the right ventricle, and anterior leaflets are larger than the have like the sail-like. So this is one clinical case, which is 30 years old pregnant woman in 26 week of gravidities. She came with dyspnea, palpitation, and dizziness. On the ECG, we have sinus tachycardia and around 115, and the normal blood pressure. So this is the echo that we performed to this lady, but this was very unsuspicious because she's never had going to the cardiologist department and never have visited her doctor. So this that we find is the Epstein anomaly for the first time. As epidemiology, the Epstein anomaly occurs less than 1% of all congenital heart disease and is around 1 for 20 or 50,000 of live births. It's very equal to male and female occurrences, and mortality in the children is presenting in the neonatal period is around 30 to 50%. Mortality is different in all ages, it's around 12%. The tricuspid valve morphology is very important. We look into about the septal and posterior leaflet, which could find displacement, dysplasia, or absence. And the anterior leaflet could be elongated, reducency, cell-like appearance, distal attachment, the mobility and defenestration of the anterior wall. Regarding this typical tricuspid valve morphology, we have some nomenclature of the classification, and which is performed by the two approach of describing the anatomy and severity of type Epstein anomaly. The first approach was based on the echocardiography appearance, which is this abnormality is described as anatomically mild, moderate, or severe, and the amount of displacement and tethering of leaflets of the degree of right ventricular dilatation also as assessed. This classification is very imprecise, but it's very simple. And the second approach, this is the Carpentier classification of the Epstein anomaly, which is proposed to follow the classification of this anomaly. Type L is the volume of the true right ventricles is very adequate. The type B is the large arterialized component of the right ventricle exists, but the anterior leaflets of the tricuspid valve is still in the movement, move freely. Type C, the anterior leaflets is severely restricted in the movement and may cause the significant obstruction of the right ventricular outflow tract. And type D is the almost complete arterialization of the ventricle except for the small infundibular component. So we look into the displacement of the valve, we look for the motion, and we looking about the contractility.
It's 22 hours.
So the another classification, which is most important to describe not only echocardiography grading of the score, which is very important from the neonates with the Epstein anomaly. This is the Zeller-Mayer index of the Epstein anomalies, which it's one of the prognostic issue from the severity of the Epstein anomaly could be used for the prognosis of this disease. The greater degree of the arterialization, it's the worse of the prognosis. We're using actually the 4-chamber view from this ratio. When we look at about the right ventricle compared with the functional right ventricle and the left heart, and the ratio from 0.5 is the grade 1, and when is the grade 4, we have the ratio more than 1.5, which is the worst for the prognosis. And regarding this Zeller-Mayer index, we could looking about the neonatal Epstein anomaly and the hemodynamical stability and stability, and the medical management, and to go to patient without surgery to fighting for the surgery for the late ages. Physiologically, the functional impairment of the right ventricle and the regurgitation of the tricuspid valve retard the forward flow of the blood to the right side of the heart. In addition, during the contraction of the atrium, the arterialized portion of the right ventricle balloons in act of the passive reservoir, decreasing the volume of the injected blood. The overall effect of the right atrium is dilatation, increasing the size of interarterial communication. Tricuspid regurgitation increased by annular dilatation, associated with the heart disease and Epstein anomaly, has the future effect of this physiology. So we looking about this echocardiography science when we identify that patient and differentiate from the other primary and secondary tricuspid regurgitation. We must define the morphology of the tricuspid valve apparatus, mechanism and the severity of tricuspid regurgitation. We could assess the right ventricle morphology, sites and right atrium sites, right ventricle, right atrial pressure, assess left ventricle morphology, sites function additional lesion when they have ASD or PFO, timing for the type tricuspid valve repair, and the follow and pre and post-operatively our patient. Echocardiography is very typical apical displacement of the septal leaflet, which is the greater than 8 mm. Abnormalities and morphology in the septal attachment of septal anterior tricuspid leaflets, eccentric leaflet cooptation, dilated right atrium, dilated right ventricle with increasing contractile performance, various left heart structure abnormalities. Looking about the assessment of the severity of surgical options, like the functional right ventricular layer, which is less than 35% of the total right ventricular area, and lateralization to functional right ventricle ratio then greater than 0.5 associated with unfavorable prognosis. Functional right ventricular sites, also the degree of septal leaflet displacement, amount of the leaflet tethering, and the magnitude of the leaflet deformity and dysplasia. Aneurysmal dilatation of the ventricle outflow tract is very important also, and linked to moderate to severe tricuspid regurgitation. The natural history is very interesting because it's not very uncommon for nestor anomaly to be undiagnosed until adulthood, like our patient. However, the late diagnosis is associated with the reduced survivals. The mean age of diagnosis in the study of the natural history on 72 and unoperated patient was around 24 years plus minus 10. In this group of the patient, arrhythmias were in the very most common clinical presentation, around 50%. The estimated cumulative overall survival rate was around 90%, 76, 53, and 41 in the first 10, 15, and 20 years when we followed this, respectively. Predictors for the cardiac-related death on unvariate analysis included the cardiothoracic ratio more than 0.65, increasing the severity of tricuspid displacement of echocardiography, the presence of the heart failure with the class 2 or 3 or 4, cyanosis, severe tricuspid regurgitation, younger ages of diagnosis, on the multivariate module, younger age of the diagnosis, male sex, cardiothoracic ratio more than 65, and the severity of tricuspid leaflet, valve leaflet displacement and echocardiography were predictor of the late cardiac mortality. We could find very associated defects like the common ASD or PFO around 19%, typically Vsd or partial AV channel defect, pulmonary stenosis or pulmonary atresia. Also could find some of the atresia of the aortic valve or aortic stenosis, valve Parkinson-White syndrome, cumulated with some of the another genetic disease like Down, Marfan, or Noonan. As conclusion, echocardiography is very crucial part of our assessment of the treatment of the patient with the tricuspid valve anomalies. The first imaging method for diagnosis, tricuspid severity, assessment of the right ventricle size and function is very important. When we're using this, the protocol for indicator storage is very mandatory for assessment and the follow-up of the patients with the Epstein anomaly. Echocardiography is very helpful for guiding the treatment strategy, type of timing of the surgery, and post-operative assessment of complication, looking for the serial right ventricle, left ventricle changes, and also looking for the quantification of the tricuspid regurgitation on right vertical sites and systolic function assessment is still very challenging, but the cardiac MRI is the gold standard still in this disease. Thank you for your attention.
Thank you, Professor Hristov. It's such an informative talk. I know, I agree. The Epstein is very rare congenital heart problems, really. Often we don't know how to assess the ventricular function. So what do you think which parameter you think is more sensible to use in assessing ventricular function in this group?
Actually, we're using 3D echocardiography for assessing the right ventricle function and assessing the tricuspid regurgitation in this patient. And to follow up with the patient is very important, especially I'm working with the pregnant woman and have to have 3 or 4 patients that we have very successful delivery and all ages around 30, 35. And this is very successful for our lab. And they are going to very well until now, and we could predict maybe in the next years when they have position to go to the surgery for the tricuspid valve replacement.
Thank you. So we had a long day today, Prof. I cannot see more questions. Do you know any questions asked?
No, I don't see any questions.
No more.
No more.
So whoever have questions, you can always put in these drop boxes and we will answer when we can. Thanks for everybody for the hard working and thanks for patience to sitting and listening. Thanks, Professor Harrisov, for another successful day.
Thank you, Professor Lee. Thank you, Professor Ho. We will going to the end for this session this evening, and tomorrow we will be online again at 9:30 Bulgarian time, which is the 7:30 London time.
Yeah.
I promise that will be very interesting day because we will have very interesting topics and very distinguished lecture again. Thank you so much and have a good night.
Sure. Thank you. Good night.
Good night.
Good night.
Да се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново. Защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академични институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.
More than 40,000 Teva employees who wake up every morning can be counted, as can the number of production sites in which they work around the world. What can't be counted is their motivation to enable someone, somewhere, to live better days with their loved ones. That's what counts. provides 35,000 products to patients, more than any other pharmaceutical company. Every day, we deliver Teva medicines to pharmacies and hospitals in more than 60 countries. These are numbers we take pride in. But what really counts is our vast contribution to humanity. Our generic medicine saved hundreds of billions of dollars in healthcare costs over the past decade. We enable access for millions of people around the world to quality medicines. For over 100 years, Teva has pioneered scientific explorations, establishing 25 cutting-edge research centers and strategically investing in biopharmaceuticals to the benefit of current and future generations. Today, our innovation has led to more than 1,000 generic medicines being developed. These are all impressive numbers that can be counted. But what counts the most is the positive impact we make on 200 million people every day who can have access to a wider range of medicines to address their health needs. Cherish the priceless times together and live better days.